Let's establish our chest pain, dyspnea, and syncope cleanup frame right out of the gate. As a third-year med student, you've got to instantly recognize the young patient crashing after a viral illness, the mother with postpartum dyspnea, the emotional stress trigger, pleuritic positional pain, pericardial calcification, and hypotension with jugular venous distension. You also need to immediately spot exertional claudication, an acute pulseless limb, a new murmur after valve replacement, recurrent epistaxis with AVMs, or collapse after stopping exercise. Today, we're locking down the exact exam-facing decision logic for these high-yield presentations.
Here's the agenda for today's explainer. Cardiomyopathy vignettes, hypertrophic cardiomyopathy, acute and constrictive pericarditis, myocarditis and tamponade, and we'll wrap up with a rapid-fire recap.
Section 1. Cardiomyopathy vignettes. We're starting with the classic presentations you are absolutely going to see on exam day.
So, what's the diagnosis here? Picture a postmenopausal woman presenting right after severe emotional or physical stress. She's got chest pain that completely mimics a myocardial infarction, her troponins are moderately bumped up, and she's in decompensated heart failure. Got your answer locked in?
If you guessed Katsubo, you nailed it. What's wild here is that the cath shows zero obstructive coronary artery disease. But look at the echo. You get that classic apical ballooning, or left ventricular apical hypokinesis, right alongside basilar hypokinesis. It's totally driven by a massive catecholamine surge from that stressor. For the exam, remember the first-line management is purely supportive care, and it usually resolves on its own over a few weeks. Now let's contrast that with peripartum cardiomyopathy. Here, you're looking for a rapid-onset systolic heart failure, with an ejection fraction dropping below 45%. The timeline is super strict for the boards. It hits in the last month of pregnancy or up to 5 months postpartum. You'll usually see this in mothers over 30, often with twins or a history of preeclampsia. You treat it with the standard systolic heart failure regimen, but do not forget to include thromboembolism prophylaxis. Oh, and a huge point on recurrence. If their ejection fraction stays low, any future pregnancy carries a really high risk of maternal mortality.
Section 2. Hypertrophic cardiomyopathy, or HOCM.
Let's look at a major structural issue that carries a massive risk for sudden cardiac death. This perfectly illustrates the mechanism of HOCM. We're talking about a genetic mutation in the cardiac sarcomere proteins, passed down in an autosomal dominant pattern. See how that thickened septum pushes right up toward the anterior mitral leaflet? During systole, that creates a dynamic left ventricular outflow tract obstruction. This explains why these patients present with exertional syncope. The outflow obstruction plus potential ischemia and arrhythmias just totally tanks forward cardiac output when they exercise.
You absolutely must recognize these ECG clues. Look closely at the precordial leads. We've got a deep S wave in V3 paired with a seriously tall R wave in AVL. Put those together, and you've got the Cornell criteria for left ventricular hypertrophy. You're also going to frequently see repolarization changes, like T-wave inversions in the anterolateral leads. Honestly, if you aren't paying attention to the full clinical picture, you could easily mistake this for ischemia.
So a huge test point is distinguishing HOCM from an athlete's heart, because both are going to give you LVH on an ECG. The tiebreaker? Echocardiography. In HOCM, you'll see focal septal hypertrophy, an enlarged left atrium, and, this is key, impaired diastolic function. An athlete's heart, on the other hand, shows symmetrical enlargement, totally normal atrial size, and perfectly normal diastolic function. This is the difference between clearing a young athlete to play or giving them strict exercise restrictions.
All right, here's your exact decision logic for managing symptomatic HOCM. Step 1 is beta blockers or non-dihydropyridine calcium channel blockers. Why? Because they increase diastolic filling time and LV blood volume, which actually pushes the outflow tract open and lessens the obstruction. You have to actively avoid dehydration and vasodilators, since they drop LV volume and make the murmur way worse. Step 2, evaluate the risk for sudden cardiac death. If they have prior syncope or a family history, they need an implantable cardioverter defibrillator. And if they're still symptomatic despite maxed out meds, you escalate to septal ablation, surgical myectomy, or even a cardiac transplant.
Section 3. Acute and constrictive pericarditis.
Stepping outside the myocardium, let's look at the sac surrounding the heart. For acute pericarditis, you are hunting for a patient with sharp, pleuritic chest pain that classically gets better the second they sit up and lean forward. Take a listen, and you'll hear a highly specific triphasic friction rub. The ECG is basically pathognomonic here, diffuse ST segment elevation combined with PR segment depression. First-line management for viral or idiopathic cases is a combo of NSAIDs and colchicine. Watch out, though. Corticosteroids are heavily tested as the wrong answer, unless the patient has a strict contraindication to NSAIDs, like severe renal failure.
Now, if that pericarditis becomes chronic, say from recurrent viral bugs, radiation, or prior surgery, the pericardium gets heavily fibrotic and calcified. This is constrictive pericarditis, and it severely blocks diastolic filling. You need to be on the lookout for right-sided failure buzzwords, peripheral edema, ascites, and a pulsatile liver. On exam, you'll hear a pericardial knock. That's an early to mid-diastolic sound of the ventricles slamming into that rigid, thickened pericardium. You'll also see the Kussmaul sign, where JVD actually goes up when they breathe in, a prominent Y descent, and low-voltage QRS complexes on the ECG. Definitive treatment? That often requires a surgical pericardiectomy.
Section 4. Myocarditis and tamponade.
Let's shift gears to when viral infections attack the heart muscle directly. A classic board scenario is a young adult or child with a recent viral prodrome, think Coxsackie B or adenovirus, who suddenly shows up with unexplained heart failure, cardiomegaly, and pulmonary edema. Echo is going to show a globally decreased ejection fraction with diffuse hypokinesis. Cardiac MRI is a great tool here, showing late epicardial enhancement, but the absolute gold standard is an endomyocardial biopsy revealing a lymphocytic infiltrate with myocyte necrosis. Treatment? Immediate supportive care for the heart failure, and you escalate to temporary ventricular assist devices if they aren't bouncing back.
Okay, what happens when fluid traps the heart completely? First, you need to know this definition cold. Pulsus paradoxus is a massive clinical clue. It's a drop in systolic blood pressure of greater than 10 millimeters of mercury during inspiration. And while we heavily associate it with cardiac tamponade, don't forget it can also pop up in severe asthma or COPD exacerbations.
Let's see how this builds into Beck's triad. Tamponade happens when blood or effusion fluid rapidly fills the pericardial space. This aggressive fluid collection physically squishes the right atrium and right ventricle. That compression forces the interventricular septum to bow way over into the left ventricular cavity during inspiration, totally crashing left ventricular preload and stroke volume. This physiological disaster gives you Beck's triad straight up: severe hypotension, jugular venous distension, and muffled heart sounds.
When you look at the ECG, you must immediately spot electrical alternance. This is where the amplitude of the QRS complex goes up and down, alternating from beat to beat. It is incredibly specific for a massive pericardial effusion causing tamponade. What you're seeing on the paper is literally the entire heart physically swinging back and forth inside a huge sack of fluid.
On imaging, the timeline is everything. An acute tamponade from, say, a ruptured ventricle will actually have a normal cardiac silhouette because the pericardium hasn't had time to stretch out. But a subacute tamponade, like from a malignant effusion slowly building up over weeks, stretches the pericardium enough to hold 1 to 2 liters of fluid. That gives you this enormous globular water bottle shape on a chest X-ray right alongside completely clear lung fields.
Section 5. Rapid Fire Recap.
Let's lock in everything we've covered with a high-yield recap of next best steps. Being able to rapid-fire these clinical decisions is what separates average scores from top percentiles. Keep these first-line treatments memorized. For torsades de pointes, if they're stable and awake, give IV magnesium. Hemodynamically unstable, defibrillate immediately. For early peri-infarction pericarditis, keep it supportive and prioritize early cardiac reperfusion. Do not give NSAIDs or steroids, they mess with myocardial healing. And finally, an unstable tamponade always, without exception, demands an emergency pericardiocentesis before you do anything else.
Let's clean up a few final high-yield vascular and systemic mimics to finish this explainer. If you see a viral prodrome leading to heart failure and electrical alternance, that dictates an immediate emergency pericardiocentesis for an evolving tamponade. For peripheral vascular disease, look for chronic edema and medial malleolar ulcers pointing to venous insufficiency. But an acute pulseless limb with pain, pallor, and poikilothermia, that's acute ischemia. It needs urgent vascular evaluation and anticoagulation. For prosthetic valves, a new murmur or hemolytic anemia means you're evaluating for a paravalvular leak or thrombosis with an echo. Keep an eye out for hereditary hemorrhagic telangiectasia in patients with recurrent epistaxis, mucocutaneous telangiectasias, and pulmonary AVMs posing a stroke risk. Lastly, if a totally healthy athlete collapses right after stopping exercise but has a normal exam, that's just exercise-associated collapse. Treat it simply with Trendelenburg positioning and oral hydration. Lock these patterns in, and you are going to crush these presentations on exam day.